Hello, this is Dr. Stephen Pipe from the University of Michigan. Welcome to this educational activity, Envisioning the Future of Emerging Nonfactor Therapies in Hemophilia A and B, the Art and Science of RNA Interference. Hemophilia is an X-linked recessive disorder present in two forms. Hemophilia A results from deficiency of coagulation factor 8, and hemophilia B results from deficiency of coagulation factor 9. Hemophilia A is about 6 times more common than hemophilia B and occurs in roughly 1 in 5,000 male births. Factor 8 and factor 9 interact within the factor 10 cleaving complex of coagulation, with factor 8 serving as the cofactor and factor 9 as the protease. The bleeding phenotype is dependent on the severity of the clotting factor deficiency. Severe hemophilia is defined as residual factor levels of less than 1% and manifests with frequent and spontaneous bleeding into muscles and soft tissues, but primarily into joints, termed hemarthrosis. Mild hemophilia is defined as residual factor levels of over 5%, and bleeding tends to be infrequent, less likely into joints, and more likely triggered by trauma or surgery. Moderate hemophilia has factor levels from 1 to 5%, and patients are less likely to exhibit spontaneous bleeding but will still have hemarthroses with injuries. There is an increased proportion of patients with severe disease with hemophilia A compared to hemophilia B. Without effective preventative treatment, repeated hemarthroses and muscle bleeds can lead to chronic disability or may be life-threatening. Repeated bleeding into the same joint, most frequently ankles, knees, and elbows, is described as target joint bleeding. These joints suffer from the effects of recurrent interarticular blood that's producing inflammatory reactions that result in progressive osteochondral degeneration that's characteristic of hemophilic arthropathy, leading to chronic pain, loss of joint range of motion, contractures, and eventually functional disability. The cumulative pathology of target joint bleeding and hemophilic arthropathy was the destiny for all patients in the pre-replacement therapy era, during which only supportive care was available. However, beginning in the late 1960s and early 1970s, the ability to fractionate factors 8 and 9 from plasma ushered in the replacement therapy era. Initially, these plasma-derived factors were provided to patients in the home setting for self-infusion episodically in response to bleeding, called on-demand therapy. However, it was recognized that this did not change the eventual outcome of the recurrent joint bleeding. Thus, prophylactic infusions of clotting factor concentrates became the standard of care to preserve joint health. We've discussed the historical impact of plasma-derived clotting factors and implementation of prophylaxis. Subsequently, persons with hemophilia were one of the earliest to benefit from the recombinant DNA era beginning in the 1990s. This technology has been leveraged further as targeted engineering has further improved the biochemical properties of these molecules. Most of our focus over the past several decades has been on the replacement therapy era. However, we now have early experience of non-factor replacement therapies with a humanized bispecific antibody, emicizumab, which substitutes for factor 8 replacement. What is currently under investigation are antagonists of the natural physiologic anticoagulants that seek to rebalance hemostasis. Specifically, a small interfering RNA knockdown of antithrombin, monoclonal antibody inhibitors directed against tissue factor pathway inhibitor, and a bioengineered serine protease inhibitor that targets activated protein C. We can also look forward to results from investigational gene therapy. This could come from gene addition, gene editing, or cellular therapies using viral or non-viral vector approaches. However, the first clinically available technology will likely be through gene addition using viral vectors. This summarizes the various bioengineering strategies that have been applied to attempt to extend the half-life of recombinant clotting factors. The addition of polyethylene glycol conjugates can reduce interaction with clearance receptors. Fusion to the Fc fragment of immunoglobulin or recombinant albumin allows for these fusion proteins to be rescued from intracellular degradation pathways through interaction with the neonatal Fc receptor and return the protein to continued plasma circulation. Targeted bioengineering has enhanced the interaction of factor 8 with von Willebrand factor its primary stabilizer within plasma, and expression of recombinant factors within human cell lines can eliminate non-human glycans that may adversely affect plasma pharmacokinetics. Pegylation and fusion technologies have led to up to 5-fold half-life extension for factor IX, whereas impacts on factor VIII half-life have been more modest. Although clotting factor replacement therapy has been the standard of care approach for preventing bleeds in hemophilia for several decades, the challenge with this approach is that the peak correction is short-lived, and as the factor is cleared, patients spend a considerable amount of time below critical plasma levels, where they may be subject to bleeding risk. This paradigm remains for the extended half-life factors, though the area under the curve may be larger. Yet as you stretch out the interval before the next dose, plasma levels may still be below levels where bleeds may occur. Alternatively, extended half-life factors can be administered maintaining the same dosing interval. This achieves a substantially increased trough level that can further reduce risk of bleeding events. Our focus for this program is on current and emerging non-factor therapies. These include emicizumab, the first approved substitution therapy, and other investigational strategies. Fitusiran, a small inhibitory RNA that targets antithrombin, and concizumab, a monoclonal antibody that targets tissue factor pathway inhibitor. What is the rationale for continued innovation toward novel approaches for hemophilia? This figure depicts the typical pattern of factor levels achieved with exogenous clotting factor concentrate replacement therapy in the lower half, and the resultant hemostatic effect in the upper half. Standard half-life factors maintain minimally effective trough levels with a regimen of typically every other day dosing for factor VIII. Extended half-life therapies can reduce the frequency of administration burden and also maintain higher trough levels. Non-factor therapies change the treatment paradigm by providing a steady-state hemostatic effect, but without a measurable factor level. The steady-state hemostasis is likely a key contributor to the enhanced efficacy observed with the non-factor therapies as compared to traditional factor replacement. The promise of gene therapy is to achieve a steady-state measurable level of factor above key thresholds that would also produce a steady-state hemostatic effect sufficient to prevent bleeds following a single treatment intervention. If we compare the strengths and weaknesses of these different approaches, standard half-life clotting factor concentrates have shown to be effective for both bleeding control and prevention. They have well-established safety and effectiveness profile for decades. They allow for measurable factor VIII and factor IX concentrations as surrogate markers of their effectiveness, and we can achieve normal concentrations of factor IX with dosing. The weakness of this approach is the need for frequent intravenous injections and consequence of inhibitor development in some patients. The extended half-life clotting factor concentrates have also been shown to be effective for both bleed control and prevention. They can allow for a reduced number of injections and achieving higher trough concentrations. They still provide measurable factor VIII and factor IX concentrations as surrogate markers of their effectiveness, and we can achieve normal concentrations of factor VIII and factor IX. But these still require the intravenous route, and patients may still be subject to inhibitor development. The non-replacement therapies allow for a subcutaneous route of administration. They typically involve very infrequent injections and usually see standard doses used across all patient groups. However, the drawback for these therapies is the need for adjunctive hemostatic treatment, as these are only prophylactic therapies and don't treat breakthrough bleeding events. The steady-state coagulation activity is likely not within the normal range, and what has been observed in the clinical trial programs and clinically to date is there can be some thrombotic risk with the use of these agents that require appropriate risk mitigation strategies depending on the modality. With gene therapy, we would have a single intravenous injection, restoration of endogenous factor VIII and factor IX production that is measurable as a surrogate marker of hemostasis. There's a number of challenges with gene therapy, of course. These include pre-existing immunity against the viral vectors, immune responses against those vectors and the transfected cells. There's an unknown durability of gene transduction, the need for immunosuppressive therapy in some cases, and we also have unknown long-term safety with this approach. Now let's look at the emerging investigational non-factor therapies. We'll discuss the recent clinical evidence on these novel therapies and how to integrate them in day-to-day clinical practice. Emicizumab is a humanized bispecific monoclonal antibody. It bridges activated factor 9 and factor 10 to restore the function of missing activated factor 8. It has no structural homology to factor 8, so it's not expected to induce factor 8 inhibitors or to be affected by the presence of factor 8 inhibitors. It has a long half-life of approximately 30 days, and it can be administered subcutaneously. And this has been approved in several countries for prophylaxis in persons with hemophilia A with and without inhibitors of all ages. Emicizumab was investigated in just under 400 patients across 4 trials, the HAVEN trials. And they cover adolescents and adults with inhibitors, pediatric inhibitors, and non-inhibitor patients. These trials established safety and efficacy with dosing regimens of weekly, every 2 weeks, and every 4 weeks. We now can evaluate longer-term outcomes for subjects who've been on these regimens for up to 4 years. The pooled annualized bleed rates have been shown to decrease over the first year after initiating prophylaxis with emicizumab, and they remain below an annualized bleed rate of 1 in all subsequent intervals for up to 4 years. Similarly, the percentage of participants who exhibited zero treated bleeds increased over the first year and remained over 80% thereafter. After at least 6 months on therapy, at least 97% of participants had less than or equal to 3 bleeds for the durations after. Concizumab is a humanized IgG4 antibody. It has a high affinity for the Kunix2 domain of tissue factor pathway inhibitor. It has demonstrated complete neutralization of tissue factor pathway inhibitor inhibition of the factor 10A tissue factor 7A complex. Daily administration of concizumab, administered subcutaneously, was evaluated in a phase 2 study in hemophilia A and hemophilia B with inhibitors. The key safety findings were there were no thromboembolic events, no adverse event-related withdrawals, and no safety concerns with breakthrough bleed treatment. The key efficacy findings were an annualized bleed rate after 24 weeks on therapy of between 3 to 7. All patients chose to continue on to the extension phase in the clinical trial program. Now let's look at the mechanism of action of small interfering RNA therapies such as Fitusiran.
Small interfering RNAs, known as siRNAs, are derived from longer double-stranded RNAs that are produced in the cell itself and can be delivered into cells for experimental or therapeutic purposes in the future. The double-stranded precursors of siRNAs bind to the dicer protein, which is an endoribonuclease protein that cuts the RNA into short segments approximately 20 to 25 base pairs long. The short double-stranded RNA then binds to an Argonaute protein. Upon binding, one strand of the RNA is selected and remains bound to the Argonaute. This is called the guiding strand. The other strand is called the passenger strand and is cleaved off and degraded selectively. The combination of the RNA and Argonaute, along with other proteins, is called the RNA-induced silencing complex, or RISC. siRNAs direct RISC to target and recognize the specific messenger RNAs and promote its binding. The binding of the mRNA is precise, with perfect complementarity between the siRNA and the target messenger RNA. Once bound, the Argonaute catalyzes cleavage of the messenger RNA, which will then be degraded. A single siRNA RISC unit can essentially target and degrade multiple mRNAs, thereby blocking the production of the disease-causing target protein. Now that we've seen how siRNA technology works, let's focus on Fitusiran. Fitusiran is an investigational therapy that harnesses the RNA interference mechanism to target antithrombin, AT, in the liver. It interferes with AT translation by binding and degrading messenger RNA, AT, thereby silencing AT gene expression enhancing thrombin generation, and promoting hemostasis in people with hemophilia A or hemophilia B with or without inhibitors. There are several therapeutic options with new biologic agents on the horizon for treating hemophilia that will likely change the treatment landscape in the next few years to provide a quality of life and life expectancy that is equivalent to those of people without a bleeding disorder. Current treatment regimens with conventional replacement therapy are effective and safe, but have some important unmet needs, such as decreasing the burden of the frequency of intravenous treatment and risk of continued breakthrough bleeding in prophylaxis. These concerns led to the investigation of different therapeutic approaches. Restoring thrombin generation has become another focus of innovation in hemophilia treatment. One new agent, Fitusiran, acts by inhibiting the liver synthesis of antithrombin, AT, which is a natural inhibitor of thrombin. By inhibiting this natural anticoagulant pathway, Fitusiran eliminates part of the anticoagulant pathway that targets several procoagulants, including thrombin, factor Xa, and factor IXA. Fitusiran is a GalNAc-tagged small interfering mRNA that is used for the post-transcriptional silencing of the antithrombin gene in hepatocytes. Upon silencing, the antithrombin protein levels in plasma are reduced, which in turn increases the overall hemostatic potential in the absence of factor VIII, generating a more stable hemostatic correction in hemophilia patients. The recent clinical evidence, which we will be discussing next, has shown a significant reduction in bleeding episodes in patients receiving Fitusiran.
You've just seen how Fitusiran works. Now let's talk more about the recent clinical evidence on Fitusiran and how to integrate these non-factor therapies in day-to-day clinical practice. Safety, tolerability, pharmacokinetics and pharmacodynamics, and dosage setting was explored in the Phase 1 program that included an open-label extension. This shows the components of the Phase 1 program and the open-label extension. The Phase 2 open-label extension study was designed to evaluate the long-term efficacy and safety of Fitusiran in adult subjects with moderate or severe hemophilia A or B with or without inhibitors, with continued monthly subcutaneous prophylactic dosing at either 50 or 80 milligrams. The efficacy and safety are being evaluated further in 3 Phase 3 studies in adolescents and adults and a separate pediatric study. Long-term safety and efficacy will be evaluated in the open-label extension for the Phase 3 program, as well as in a pediatric extension study. As can be seen on the left panel, antithrombin lowering occurs quickly upon dosing at either 50 milligrams or 80 milligrams monthly, reaching a nadir beyond 2 weeks post-dose, and is sustained at levels at or below 20% in subjects who remain on monthly subcutaneous prophylaxis. On the right panel, this antithrombin lowering leads to thrombin generation levels that in some cases is approaching the mid-range in healthy volunteers, as indicated by the shaded area. Following antithrombin knockdown, subjects achieved overall median ABR of less than 1 during the observation period, and similar results were achieved in hemophilia A and hemophilia B with and without inhibitors, and compares favorably to pre-study annualized bleed rates in subjects treated on demand or on prophylaxis. Breakthrough bleeds were mostly located in joints, they were mild in severity, and they tended to be more spontaneous in those with inhibitors. Overall, the Phase 2 open-label extension interim analysis has shown that Fitusiran was generally well tolerated and led to dose-dependent antithrombin lowering, increased thrombin generation, and decreased bleeding frequency. Now, let's see how we can translate the evolving evidence into practice in real-world settings. Every patient represents a unique challenge. A single severity-based therapeutic model does not represent the optimal treatment strategy for all patients with hemophilia. Individualization of their care is recommended. These are some of the factors to consider in order to individualize treatment. The patient's personal bleeding pattern, the condition of the patient's underlying musculoskeletal system, the level and timing of their physical activity, their individual pharmacokinetic profile with their therapeutic agent, whether they have the presence of a central venous access device, whether they have target joints, the patient likelihood of good adherence to the prophylactic strategy, and other psychosocial factors. All of these underscores the need for shared decision making in identifying the optimal regimen for the patient. Goals of shared decision making are to inform the patient, to improve their knowledge about their own illness, to activate the patient to increase their role that they assume in their illness management, and to promote interaction between the patient and the healthcare professional. So as we conclude, these are some of the evolving trends that we can see with modern therapeutics for hemophilia. With factor replacement therapy, we're moving towards bioengineering strategies that make even once weekly dosing strategies possible. Pharmacokinetic supported therapy is allowing additional optimization for patients using these factor replacement therapies. The flexibility that they provide allow us to normalize hemostasis as needed and perhaps targeting that with activity levels. Routine monitoring is available with the use of these agents, and prophylaxis and breakthrough bleeding may be treated with the same agent. With the substitution and rebalancing therapies, these are typically administered as a fixed dosing regimen, weekly to monthly. They likely achieve subnormal hemostasis, but the steady state activity is what helps with their overall efficacy. They pose laboratory monitoring challenges since we're not actually replacing factor VIII or factor IX. Personalization for optimization of prophylaxis is currently limited with these agents. What we observe clinically is the patients feel that they have been liberated from routinely having to think about their hemophilia, and this is probably another advantage of the steady state correction. We do, however, have continued reliance on factor replacement therapy to manage breakthrough bleeding events. The limitation of these approaches overall has been some thrombotic complications that have been related primarily to management of these breakthrough bleeding events. And these have all required some risk mitigation strategies that have been implemented either into their clinical use or the ongoing investigative clinical trial programs. Some key take-home points from today's program. The treatment of hemophilia has evolved considerably over the past several years. Advances in biotechnology have permitted the development of extended half-life replacement clotting factors for prophylaxis in patients with hemophilia A or hemophilia B. Novel non-factor therapies are being evaluated in hemophilia A and B. Patient education is essential for enrollment into clinical trials to further the development of these novel hemophilia therapeutics. An important goal of comprehensive care is for hemophilia patients and their family members to be well educated in their disease and its management, and this can significantly reduce morbidity and mortality and underscores their role in shared decision making. Shared decision making strategies have shown to increase the use of the treatment option that is most clearly associated with health benefits for that patient. The novel therapeutics we discussed in this program, including emicizumab, fitusiran, and concizumab, have changed the paradigm for prophylaxis in hemophilia. The unique subcutaneous delivery, steady state hemostasis, and long duration of effect have significantly reduced the treatment burden while providing improved outcomes for patients.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer View Institute for Medical Education.